Thank you for the lovely introduction, Anna. And many of you would have heard me talk just recently with the wonderful Anna Marie Madeley, sharing our research insights. So this is kind of a development or building on that. And I saw this really cute picture and I thought, actually, this is great. This really sums up this idea of working together, that we all need to be working together to support women and birthing people's experiences of maternity care, and one that is personalised to the individual. But in order to do that, and definitely Becky's given us the everyday insights of what that actually looks like, having a cup of tea, sharing office spaces, sharing environments, because what we need to do in order to fulfill the needs of people in our care, we need to address the needs of the professionals, so we can all authentically support that individualised, safe care. And what I'm talking about tonight was also published in the Practicing Midwife, and it's there this month. And there's the citation there, and I think someone's going to pop the link into the chat so you can link straight to it. So, there's more details in there. Of course, and I won't spend too much time on this because we all know this. We know choices matter, and we know that women and birthing people deserve and should expect to maintain control, dignity, respect, and bodily autonomy. And this is all linked to the Human Rights in Childbirth framework. And all of this is linked to safe and personalised care. But we know we are living in a very complex cultural arena, if you like, where we know choice and autonomy. We've got a very strong rhetoric for that. We've got the best legislation in the world, I would argue. We've got some of the best policy in the world. But we know on the ground and in reality, actually delivering and fulfilling a truly autonomous agenda can be very challenging. And this can be a combination of reasons, wider discourses around medicalisation, institutionalisation, perhaps more so than medicalisation. We've got risk-averse litigation and issues around, or challenges, should I say, with governance. Not governments, governance. And of course, simultaneously, we've got issues for those people who do want extra medical care, medical interventions. They also find it challenging to get their needs met. And as I've said before, we also, within this complex area, midwives, we're not a homogenous group. Obstetricians are not a homogenous group. No professional group is homogenous. And of course, midwives, how they view and their philosophy and their values will influence how they deliver their care in terms of personalisation. And as I've said before, in terms of safety, we need to just remember when we're considering out of guidelines, which is kind of always defaults that to the negative, but I call it alternative physiological births, which is a complete mouthful and not very smooth to say. But when we think about out of guidelines normal births, we really need to think that safety is more than one aspect. It can't just be one aspect. It's holistic, it's biopsychosocial, cultural and spiritual. And most importantly, however uncomfortable some people's and women's decisions make us, we have to remember that safety is perceived differently by everyone. And it's our jobs to ascertain what that individual's perception of safety is. And of course, and especially listening to Becky, of how you can cultivate that through trusting relationships. So I just always like to put this caveat in because I know out of guidelines normal births can make some professionals feel uncomfortable. But when we look at it in this more broader view, then and when we see the person before we see their risk factor, and I'm putting that in inverted commas, then that does change, that shifts things. And as you know, you've seen this before, many of you have seen this before, the types of decisions that the midwives in my PhD study were involved with. And you've got, either women with healthy pregnancies but declining aspects of care, like examinations or post-dates inductions, or you've got women or birthing people with more complicated pregnancy, perhaps obstetric risk factors or medical issues. But I always like to put an acknowledgement here, because as much as I've spent a lot of time immersed in the literature, in the research, and carrying out the research, particularly for women who had opted to free birth, prior to this particular study, I think it's also really important to appreciate and for me to fully acknowledge the challenges that midwives face when someone does opt for outside the guidelines. While many of the midwives in my study, PhD study, did face pressures, and I shared that with you last time, they personally and proactively supported these choices. So their philosophy and skills were aligned to those decisions. And I appreciate that isn't the same for everyone. And also, I know that depending where you work and who you work with and the service you work within, a request outside of guidelines might be causing and may cause all sorts of worries and fears. Sometimes women making these choices can stir feelings of concern and anxiety, and sometimes we can catastrophize, worrying about jumping to the adverse outcome and risk of litigation. And this is particularly worrying and particularly frightening if you haven't experienced that particular type of birth choice, if you've not been involved in the care. And as we, again, linking back to Becky's presentation, thinking about the embodied experience that her and her colleagues are building up over time as they support true personalised care. But if it's the first time you've come across perhaps someone wanting a vaginal birth after cesarean at home, then it's understandable and natural for it to feel somewhat slight concern. And if you're not in a supportive and enabling environment, then that can actually feel quite threatening for women making some of these decisions. And we know that through the research. I know that from my research that I shared with you last time, that some of you are going to be listening tonight, are going to be working in very challenging work environments and where people and your colleagues don't necessarily support women's full autonomy. So I just wanted to acknowledge that, and also acknowledge that we all have our own reactions and responses when we are offering truly personalised care, and that is completely normal and natural, but our job is to be able to be self-aware and be able to put those things to one side, of course, but we also need to be in supportive environments, which is where a lot of this model has come from. So you've seen this before, many of you have seen this before. We know how the midwives delivered the personalised care for alternative physiological births. And broadly, you can see active support, relational trusting care, ongoing discussions, finding out what a person's non-negotiables were, care planning, liaising with the multidisciplinary team as appropriate. But depending where the midwives worked, this could be a really straightforward process or a super challenging process requiring lots of emotional or mental labour. And in my study, the midwives worked in a range of environments where for some, this care was the absolute norm, and for others, it was delivering this care was fraught with difficulties and challenges. But in my last talks, where I presented this second analysis that explored the midwives' experiences of delivering their care and very much talked about their workplace environments and how much that influenced how the midwives were able to get on with the job, and certainly how they felt and experienced delivering personalised care. But on reflection from that last presentation, I realised I did focus too much on the negative. And as you can see from this little diagram here, there was much more to it. There was much more rich stories beyond the stories of distress. And I just wanted to counterbalance that and share with you just briefly something from the stories of fulfillment before moving on to the model itself, because it is really important to learn from what works and where it's working well. And we've already had this inspirational presentation from Becky, and this hopefully reinforces that. So in the study of 45 midwives, 21, and how inspiring and optimistic does that make us? 21 out of the 45 actually had how I captured these stories of fulfillment. And for some, and I remember last time I talked about very much it was the workplace that mediated how midwives felt and experienced their practice. So in the stories of fulfillment, for some of the midwives, this related to the sense of the ordinary, where their midwife practice was marked by a lack of conflict, animosity, or distress. Rather, they were just simply able to get on with the job. And then that was because the midwives were in supportive working environments where women's alternative choices were mostly accepted, and midwives' practice was supported from across the organisation. And then for other midwives, their narratives related to a sense of camaraderie between themselves in these small relational teams and to the women and themselves in this team. So you have these stories of togetherness. And then finally, some of the other participants expressed a feeling of the sublime. And then through counts of love, awe, tenderness, attunement, and reverence. And in these situations, the organisational culture and issues faded away into the background. They became decentered, so that the mother midwife, the family midwife relationship was the central focus. And in a minute, I'll press play, and this is one of the quotes from my study, and you can hear in the voiceover the joy and beauty of facilitating this family's birth. And a side note for context, that this midwife had cared for this family over several pregnancies, and not all of them were happy outcomes. So this pregnancy, this birth, was made all the more meaningful as the midwife journeyed wholeheartedly with the family, giving everything she could to make it the best experience possible. And I think I've clicked the right box, so hopefully you can hear this.
You know, one frosty March morning, I was called to her, and we had a nice wood-burning stove on, with some marmalade on toast, and she had a beautiful water birth. And prior to her going in the pool, her little son had been in the pool, so we made it quite jolly. And then she birthed, and she had a little girl. You know, it was one of the most privileged times that I've ever had in my career. It makes me want to cry when I think about it. You know, I felt so privileged to be there and to be part of their experience and part of their life for such a long time. I've been through so much with them. And you know, I'd seen your flyer the other day, and I seen this couple out shopping. I ain't seen them for ages. And I said, funny thing is, I was thinking about the baby and how old she was now, and I was saying to them how privileged I felt about being there. And they said to me, no, it was a privilege that you were there with us, because you've been through so much with us. But like I said, it sounds silly, but it does make me want to cry, because I do feel it was so, you know, one of the pinnacles of my career. It's something I always think about. That moment she came up in the water. And you know, it wouldn't have mattered if it was a boy. But I just thought, you know, the fact that it was a little girl, after all that time, you know, that was fantastic as well.
So just to counterbalance the perhaps more negative from the last presentation. So when we're looking across when I was looking across the data set, and I did these 3 different analyses, although one's yet to be published, you then have to ask the question of, so what? What does this mean for practice beyond sharing the important stories and lived experience of the midwives? And of course, that is a worthy endeavour, and I'm really glad to have shared what I have shared so far. But in order to, you know, support practice, what I wanted to do was think about this so what. So this asset model was developed, and it's a tool that can be used for both us as individual practitioners to consider our needs, everyday needs, and perhaps consider where our gaps are and how we can fulfill those gaps. But it is also a model that can be used by organisations to consider whether they have the right components in place to ensure midwives are enabled and supported to deliver authentically personalised care. And we know it's a key policy driver at the moment, so perhaps this could possibly help. So this model, a play on the word asset, is to show that midwives are the asset for women and birthing people to get their needs met. And it also situates what midwives need from an individual level across to an organisational level, and as you can see from these words here. And the idea here is that while individual midwives, yes, make a big difference to women's experiences of care, it is essential that personalised care, out of guidelines care, is viewed as a collective responsibility, whereby the service is able to meet the needs of the women by supporting the midwives and, of course, obstetricians and wider MDT to deliver the care that they are trained to do. So I'm just briefly going to go through two aspects of this because I think they're particularly pertinent at the moment. And if we think about skills and skill development, as is something midwives need. So it's absolutely essential. And for the midwives in this study, they shared the extensive experience they had in supporting physiological labour and birth. They had expertise and which created the competence to apply those skills to more complex alternative birthing decisions or situations. So when facing a complex alternative birthing decision, such as twins in water, they referred back to their knowledge of anatomy and physiology and applied it to the current situation. And so working through a range of possible scenarios, practical simulations, the midwives demonstrated careful planning and contingency planning based on enhancing the physiology. Such expertise was gained from actively seeking opportunities, either as a student or once qualified. So they may have asked for specific mentoring or requesting to work at a birth centre or joining a home birth or caseloading team. For others, they just happened to be in the right place at the right time. Someone took them under their wing and shared with them and helped them develop these skills. So for safe care, we need to think about, it cannot be the individual burden to get these skills. It must be supported from a systems approach to cultivate and develop, enhance and keep creating the opportunities for the skills. And this is, of course, links to CPD. And it's got to be the role of the organisation to help midwives access opportunities for ongoing skill development in physiological births. Trust must ensure that these training needs and development are met for midwives working in all areas of clinical practice, particularly with the continuity rollout. And lots of midwives are moving from their usual place of work. This is an ideal opportunity to upskill and reskill the workforce, as is going on already. And we can see a great example by Dr. Shawn Walker. What she's doing around breech birth gives us all optimism to demonstrate how, where skills have been lost, we not only can we regain those skills, but we can actually improve on what we were doing before. And then finally, I just wanted to focus, this is probably one of the most important parts of the model when we think about, we've got to keep a systems approach in mind. Yes, individual midwives, we do have a responsibility for our own learning and education, but we also need to consider where we are in the ecosystem of NHS care. So in opnology and some of the fears around supporting these birth choices, this is where the systems approach is vital. And as I've said, we do have an individual ethical and moral legal duties in terms of the care that we give, but we also have to address the systemic issues. And as I've said before, some of the participants in my study did work in hostile environments where the general culture was unsupportive of midwifery and women's autonomy, and there was negative, poor working relationships. So if a midwife is working as a lone ranger, delivering authentic woman-centred care that women are asking for, this is completely unsustainable and leads to distress and burnout, which we know is one of the leading factors in why midwives leave the profession. But on the flip reverse of that, where participants worked in these supportive environments, where the organisational values and culture created the optimal environment for midwives to deliver women-centred care, where these choices, where women having a choice, as we saw in Becky, women having a choice was normalised. It was everyday practice. And this creates that lovely virtuous cycle, positive cultures which go beyond an individual midwife or an individual team, and it actually then spreads out or comes in from the wider organisation. And this is important because then it shifts the burden of delivering women-centred care from just an individual doing it, and rather it becomes a shared vision and a collective responsibility across an organisation. And this is where values of women's autonomy over organisational needs and trust in midwives to deliver care are crucial. So midwives need support that is accessible, timely and restorative. For my study, sometimes that was as simple as calling a senior or consultant midwife for reassurance that the care plan was appropriate. Sometimes it was just a brainstorm a situation which may have become unexpectedly complex. So having a senior midwife on call, for example, quick phone call to sort through something. Sometimes it meant having a structured multidisciplinary team meeting with professionals across the different sectors to come together and create a care plan, but where that's centered on the woman or birthing person's needs. And then simultaneously, that helped ensure that components of safety were factored in. So everyone brought their strengths, skill sets, areas of expertise, and really had a conversation and checked in with each other. Have we thought about this properly? Have we thought about that properly? But all the while centering the woman's as their decision as centre and first and foremost. And we know that where the multidisciplinary team was approachable, just again, as Becky has talked about, and was available and easily available for supportive, constructive discussions, that provided another robust layer of support and enhances the psychological safety for midwives, which of course enhances the safety for women, families. Teams that work well together deliver the most optimal outcomes. And then for others, support came from debriefing through challenging episodes, which, if carried out in an open learning culture, enhance the midwife's well-being, their clinical skills and their practice. And in other areas, support was cultivated through formalised care plans, care planning, pro formas, guidelines, and for most of the midwives, that was viewed as supportive mechanisms. But a fundamental message here is that midwives need to know that they have the support of the organisation as a whole, from the managers to the heads of midwifery, to their MDT, to their immediate colleagues. Having organisational support and psychologically safe working environments reduces the potential for distress and burnout, which absolutely mirrors the literature that we already know about. And so fundamentally, this model supports the ongoing message that a systems approach to maternity care is essential to improve both safety and dignified, respectful maternity care for women and birthing people. Staff need open and enabling and psychologically safe working environments. And we all need to work together to provide the safe, personalised care. And just finally, I just want to say thank you. Remember, each and every one of you make a difference. Every interaction you have can lift women up to feel empowered about their birth choices. And the love and care you bring into your practice, even when you're facing your own concerns and challenges, goes such a huge way to readdressing the imbalances within maternity care. So for that, I thank you. And thank you so much.